During the Phalansteal incision, the skin is incised horizontally, approximately 2 cm above the pubic symphysis. This incision is approximately 8 to 12 cm in length and is located between the superficial epigastric arteries from both sides. The initial skin incision is retracted to proximal and distal. The subcutaneous tissue is separated with electrocautery until scalpus fascia is reached and transected. The anterior rectus sheath is shown after the completion of the dissection of the subcutaneous tissue. Once the anterior rectus sheath is exposed, it is incised transversely along the length of the skin incision. The incision may be enlarged laterally with the incision of the external oblique fascia. Be careful of the iliohypogastric and ilioinguinal nerves at the lateral sides. Nerve entrapment is a common complication after lateral extensions. The rectus muscle is then freed from the fascia. Under continuous tension, the anterior rectus sheath is easily separated from the underlying muscles by blunt and sharp dissection. Distally, the rectus muscle is mobilized towards the pubic bone. Mobilization of the rectus muscle towards proximal is made as far as the peritoneum opening should reach. Lateral mobilization is carried out to the edges of the rectus muscle. During this step, all perforating vessels are dealt with by electrocautery. The rectus muscle should be split in the midline, the linea alba. This is accomplished by placing 2 closed forceps through the linea alba. In case of adhesions of the rectus muscle, sharp dissection may be necessary. The remaining part of the anterior rectus sheath is shown here, with the rectus muscle more in detail. After sideward retraction of the rectus muscles, the peritoneum is visible. Remember, at this level of rectus muscle, below the linea semicircularis, there is no posterior rectus sheath. The peritoneum is picked up between tissue forceps. Postpone cutting the peritoneum until the Silvocine is seen. Silvocine is the reflection of the scissor blade through the peritoneum. The initial entry is then widened sharply to a longitudinal incision with scissors. Be careful not to damage underlying bowel. Extending towards distal, be sure to identify and retract the bladder to avoid damaging this organ. The peritoneum should be approximated with a running absorbable suture. Here, the anterior rectus sheath is shown again, the rectus muscle posterior to it, and the peritoneum. The transversely opened anterior rectus sheath is approximated with a slow absorbable running suture. The rectus muscle is not closed separately. Post-operative, the muscle will relax and fall back in its original place. The approximated anterior rectus sheath is shown here, the subcutaneous fat tissue anterior to it, and the fascia of Scarpa, which is often clear in young patients and diminishes frequently in older patients. If present, Scarpa's fascia is approximated with a few standing absorbable sutures. The skin is closed preferably with running intracutaneous absorbable monofilament suture. In case of a higher risk of wound infection, the skin may be closed with standing non-absorbable monofilament sutures or skin staples.